All right, welcome back, everybody. I hope you had a nice lunch break. We are excited for our next presentation. Again, we encourage you to put first and last name so that it aligns with your registration name for the giveaways. We remind you to complete the evaluation at the end of the day, which also gives you an opportunity. And I also want to remind you too of our scholarship for submitting a 500-word essay on a desired career path that explains educational and professional elements to reach your career goal for a chance to win $300. So that's due by the end of the day on Monday, the 20th of June. So without further ado, I want to introduce Amy Walls, the Director of Imaging Services at VCU Health Tappahannock Hospital, and she will be presenting today on radiology.
Good afternoon, everybody. Can y'all all hear me okay? All right. So I've got the after lunch session. Hopefully I don't put anybody to sleep. Well, like Stacey said, my name's Amy Walls. I've been working at VCU Health Tappahannock Hospital now for, it will be, gosh, just talking about that with Stacey, it'll be 21 years this fall. I actually started in the imaging department here when I was in high school as an aide in the department. They've got, back then we had film. It wasn't, things weren't digital. We didn't have our magical digital plate that you put in the, where we take our pictures in the bucket and hit the button and the pictures show up on our computer screen for us now. Back then it was after every picture, you had to pull that film out. You had to go in a dark room. You had to run it through the processor and wait for it to come out. So that is what I was doing when I first started out at imaging. Since then, I have gotten my radiology license through Riverside School of Health Careers. Came back to Riverside Tappahannock at the time. And started working in X-ray. They cross-trained me in CT. And then I was also trained in mammography here. So that is one really good thing about working in these rural community hospitals is that you have opportunities to cross-train into other modalities. The two modalities that we're going to spend a lot of our time talking about today is CT and mammography, which are the two of my backgrounds. Let's see. So did both of those for probably about 10 years, and about 5 years ago, I got into leadership within the imaging department as a supervisor, and then 2 years ago promoted to the role of director of the department. So I oversee all of the imaging departments within VCU Health Tappahannock Hospital. That includes X-ray, CT, mammo, echo, ultrasound, nuclear medicine, PET scans, MRI, bone density, and I'm sure I'm forgetting something, but it's lots of fun stuff. All right, if I can't get this to go to the next slide for us. Before I get any further, I just wanted to draw y'all's attention to the ARRT website. This is the American Registry of Radiology Technologists. It is where, if you want to get into this field, it's who you have to take your test through to get your registry to be able to work in the hospital setting. You can go to this website and get all kinds of information on the different modalities within imaging, the schooling that you need. You can find the test requirements, the things you need to do before you can actually sit for that test to get your credentials. It also tells you about the different schools that are approved. And you've got in there as well, there's a test with everything. So it breaks down what's on each test for each modality. So it is a very, very, very helpful website, has lots of really good information. So just, if this is something you do want to get into, I highly recommend going to that website and checking out what you can do to get into the different modalities and what needs to be done to get into the field of radiology. All right. Radiology services, there are what they call primary and secondary certifications. So you can't just say, I want to be a mammography technologist, or a CT technologist. You actually have to go to school first to become a radiology technologist and get one of your primary certifications. And then from there, you can get those secondary certifications, such as the ones that are listed here: CT, bone density, mammo, MRI, cardiac interventional radiography, breast sonography, vascular sonography, vascular interventional radiography, So there's lots of them out there. That is one great thing about being in this field. Once you get in it and get one of those primary certifications, there are so many other things that you can go out and do and become a, you take x-ray for a couple of years, you get tired of it. You don't have to go through and go to college again and sit for 4 more years and come up with a new degree to find a new job. You just look at these secondary certifications, pick one that interests you. A lot of this stuff is that you can do on the job. You can do online through different computer modules. There's at-home book studies that you can do to get these certifications. So it really does, once you get those primary certifications, opens the door to so much more. And that's just being a technologist in the field doing patients. That doesn't even begin to get into the quality aspects of being in radiology and being someone who looks at all like the quality matrix that go along with working in healthcare and making sure you're doing things as you should, getting into the leadership roles of it, whether it's being a manager, supervisor, lead tech, director of the department. So having all these backgrounds is what's going to get you to those next levels within imaging. All right. So does anybody know what this is? Any guesses? Say, y'all can put it in the chat box, except I'm not exactly sure where my chat box went to.
We have MRI, CT.
It is a CT scanner. And for those of you who said MRI, you're not too far off. MRI scanner looks very, very similar to this. The circle part in the middle of this, where that table is going to go through, is a little bit longer for the MRI scanner. That's why patients have such a hard time with it, because they feel claustrophobic. So they're in more of a tunnel than just that, what we consider a donut. So yes, that is the CT scanner. All right. So what is CT? CT is an imaging modality that produces ionizing radiation to image all different parts of the body for various diagnoses by taking pictures and slices. So what do I mean by that? So imagine you've got a loaf of bread in front of you that's been cut like you would get from the store. And instead of like taking the front piece off of it, you grab a piece from the middle, slide it out, and you can see all the different air bubbles and textures within that loaf of bread. That are the type of pictures that we get from our CT scanner. So you put a person, lay them on that table, in that previous picture I was just showing y'all, they slide through that donut machine, they come back out, takes a couple of seconds, and we have hundreds of pictures and very thin little slices that we can send off to the radiologist, manipulate different ways that they want us to manipulate them in, send them off to the radiologist, and they're able to use them for their diagnosis on whatever it is they're looking for that patient. Regular x-ray is kind of like you're just taking a picture of somebody. It gets the, you can see inside the body, obviously, but it has everything kind of laying on top of each other. So, your ribs sit on top of your lungs, which sit on top of your heart, which sit on top of your, ribs are in front and back of you. So on the ribs again, before you got that one image. So it's all of that on top of each other in x-ray, whereas CT, we're able to kind of pull those different things away, and by doing the different slices, and see just the heart or see just the lungs or look at just the ribs. So CT protocols are built in the scanner to be able to perform different scans on different body parts. So each hospital outpatient setting, let's see, trying to think of other places you can go get CT scans done, but anywhere you go, any organization, they're going to have different protocols specific to that organization that the radiologists approve. And those are what's put into the scanner so that you're able to give the radiologist what they want. So we might take some pictures of your belly, but not everyone who's getting a belly scan is getting the same belly scan. It kind of depends on what we're looking for. So if they're looking for kidney stones, you might get contrast, you might not. It depends on what they're worried for with those kidney stones. Are they worried for a blockage? You're going to get contrast. If you're not worried for that blockage, you don't give contrast. That's one of the things with being that CT tech, you've got to know what protocol to use based on what the doctor's looking for the radiologist. So there is a lot of communication that goes on between the technologist and the radiologist to make sure we're doing the right protocols for the patients in CT. Speaking of contrast, CT does utilize 2 different types of contrast to help with diagnosis. There's oral contrast at the patient's drink. It's that thick, white, chalky, we call it barium. We do have different flavors that it comes in, so that helps with people in the taste. And we also have IV contrast, where we'll have to start that IV in the patient's arm and inject that contrast. The difference between these 2 contrasts, the oral contrast, what it does is coats your intestines really well. So that way we're able to see your intestines real good. And then the IV contrast highlights everything else. So it'll highlight your organs in there, your kidneys, your liver, and all of your blood vessels running throughout your body so that those are able to be seen very well. And as I said earlier, CT scans are really quick. They can be done within a couple of seconds to several minutes. It just depends on the scan type. The ones that get to be several minutes long, those are ones that we're usually looking for. We're getting what we call delayed images. So you're not actually scanning for several minutes. You take some pictures, the patient lays on the table for a little while, and then you go back, and I say a little while, I mean like 2 or 3 minutes, and then you go back and you take some more pictures. One example of why we would do that is going back to the kidney stone patients. If we're waiting to see how long it takes for that IV contrast we've injected, now to go from the kidneys down to the bladder. So we wait 5 minutes and we scan again to see how much that bladder is filled up with the contrast. And then that kind of gives the radiologist an idea of what kind of blockage is there a blockage and how bad that blockage is. Any questions? And I don't know how or why I lost I normally can see a chat box. But it did just
quick question in regards to the education. So you talk about the radiology technologist or what have you. RCC is actually about to release, I guess, a sonography program.
Yes.
So if someone received that degree and then came to work for you all, exactly like what kind of roles would they be eligible for versus, having, I guess, your radiology degree?
Yeah. So in sonography, and I don't want to we've got Joanne presenting on that later in the week, so I don't want to take up too much of what she could present on, but sonography there's so many different specialties you can get into. So if you just go in for general sonography, then you can get into the other fields of sonography. So vascular sonography, cardiac sonography, breast sonography. Or if you wanted to cross-train into another modality altogether, sonography, it does limit you a little bit because there's no ionizing radiation in sonography. It's all sound waves. So you could get into MRI, which also does not use ionizing radiation. It's a big magnet. So you could get into cross-train into MRI from sonography. And then of course, all your typical leadership roles. Sonography is one of the more regulated modalities. So you've got your American College of Radiology accreditation, your ACR. So you've got to make sure you're scanning to ACR standards. And there's usually an accreditation specialist that will oversee that in ultrasound. So that's another potential pathway that people can get into from sonography. And I do hit on, I think, a little bit more education towards CT and mammo throughout this presentation. Anything else before I move on? Still got more CT stuff. Okay. All right. So what do if you become a CT tech, what do you do? Besides putting patients on that table and sending them through the donut hole. So when you're in a hospital setting, it kind of depends on how the hospitals are set up. But here at Tappahannock, we do not have any transporters. So it's up to the technologists to go get their patients. They've got to go to the emergency room, either down to the inpatient unit or the outpatient waiting area. They've got to make sure, and this is for any modality, anything you do in a hospital or any type of imaging center, make sure you've got that correct patient, correct procedure, and correct protocol. Difference between procedure and protocol. So like I was talking about earlier, we'll have that, say a CT of the belly. You've got that as the procedure, but then the protocol will be, what are we looking for to know exactly how we need to scan this belly CT? You also need to confirm that there's no contraindications to contrast and start the IV line. That is something that would be different at different organizations you go to work at. And I shouldn't even say different organizations because it's even different within VCU here. At Tappahannock, we, the technologists, I say we, are the ones that are confirming there's no contraindications to the contrast and starting that IV. At bigger facilities like VCU Maine downtown, you've got a radiology nurse that will be doing that piece of it. So depending on where you work, what your job roles will be for each modality. You've got to make sure you're achieving quality images for the radiologist and know what they look like. Patients ask us all the time, you do this, I know you know what you're looking at. We get a little bit of training in how to read images, but our main goal when we're going through school is not so much to diagnose, but making sure we have everything on those images that the radiologist needs to diagnose. So we got to make sure we get those quality images. There's no motion on them. Did we get all the anatomy that we needed? Did we use contrast when we were supposed to use contrast? Not every IV you start's a good IV. Sometimes those IVs don't work. So making sure that it's a good working IV to get that contrast to where it needs to go to get those images. Post-processing images as needed based on the protocol. So we get our one scan that we do, and I've got some pictures to show y'all coming up. So we do our one scan, we get our axial images from that one scan, and then the technologist can manipulate those images. And instead of looking at the person face on, you could be looking at them from the side. So you can, it's really cool the different manipulations you can do with these images. Instead of describing them, I will show y'all pictures. And you also assist the provider in CT guided procedures. So some of those procedures that we do in CT are biopsies, drainage, or tube placements. And again, depending on where you work, it's how much you'll do this. Here at Tappahannock, we don't do a whole lot of CT guided procedures. Some of the main ones that we do is any lung biopsies. So it's just, and then the patient into the scanner, identifying that small little area, and we're talking area like millimeter size, that the radiologist is going to put the needle in to get the sample. So you're helping him locate that spot that he or she is going to put that needle in. The bone marrow biopsies, what was the other one? The bone marrow biopsies is another one that we do. Those aren't as localized as like the lung biopsies. So those are a little bit more easier to do. Those are the two frequent ones we see here at Tappahannock. VCU Maine, they've got a CT scanner that all day long, all they do is procedures on it. And that all again goes back to where you're working. It kind of depends on what exactly you'll be doing. All right, pictures. Who doesn't love pictures? So what can CT be used to diagnose? Strokes, fractures, internal bleeding, GI issues, blood clots, spinal cord injuries, urinary tract issues, cancer follow-up for growth and staging. So this picture that's here in the middle, this is your typical CT, what they consider an axial slice. If you look over to the right, you'll see that same CT slice again, that axial slice. So that was all those three different pictures that are here came from one scan. So you've got that axial slice here that was then manipulated by the technologist in the post-processing. And this, for those of you not used to looking at x-rays, so like these are your kidneys. This is like if you're looking at a person straight on, if you were to cut them in half from head to toe, and you're looking at their body straight on, you've got those are the base of the lungs, those dark areas. And then these are your kidneys. You've got your liver and spleen. This is the spine coming through here. Oh, not there yet. And then this other little teeny picture here, this is the side view. So instead of cutting me front to back, you're cutting me left to right and looking at me from the side so you can see the spine and the side view. And then all of the intestines, liver, that's the base of the heart, that little bright thing way up there at the top. And the brightness in this picture here, the middle one, going back to that one, that's where someone has drank the oral contrast. So that's highlighting their intestines real good for us. I don't know why it keeps jumping. It just wants me to go to that next slide so bad. And then over here, pictures of the brain. So same thing, you've got these right here are the way are your axial images. So those are the ones that come up right away when you scan. And then the technologist is post-process to get these pictures, which are, again, if you cut me in half from front to back. And then these are pictures if you cut them in half from left to right. So one scan can get you all these different pictures. Just one of the things that drew me to CT was all the fun stuff that you could do in there with the pictures after you scan the patient. This kind of gives you a little idea of what it looks like in a CT room when you've got a patient on the table and they're going through the donut hole machine. This little thing that's attached to them right here is the injector. And that is where you're going to put your contrast. Once you start your IV, you hook the patient up to it. You don't come out in the room and start that. You control, I don't know if you can see the little person behind the window here. And unlike every doctor show you see on TV, that's the way to put it, medical show you see on TV, it's not the doctor doing these scans, it's the technologist. And so you've got the little technologist standing back there. All right, now I've got some more pictures of post-processing in CT. So this one, you would have gotten those same axial pictures that I showed you in the other slide. So the ones that look like this, that's that axial picture. And then these are of lungs. And then that's a front to back one again that came from the same scan. So this same scan that was done here would have originally, this of your knee would have looked like that. And then these pictures are then post-processed in a different program to where it removed everything but the patient's bone. And then you can see the knee, a front view, and then a side view of the knee. Same thing happened with these pictures of the abdomen. This is probably where I should have started. So this was your original scan. It was that axial scan again, and then they manipulated it into a front to back view. And then in this one, they removed everything but the bones out of it. And then in this view here, they've removed everything except for the kidney. You've still got some bone in it, but you've got your kidneys there and the vascular that's going to the vascular structures that are going to the kidneys. So you've got your liver that's a little bit highlighted here in the portal vein and everything that's coming down through there. So all of that is done. You scan a patient one time and then you post-process to get these images. Very cool. All right. Y'all still with me? Not napping from lunch yet? Okay. So how do you become a CT technologist? That's going back to the primary schooling. You'll need to get your primary in a radiology field background, so radiography, nuclear medicine. A lot of the techs that come into CT start out as a radiology technologist, so they're taking x-rays and then cross-train into CT. And in nuclear medicine's another one we see a lot of CT techs come from, because the world of PET that they do and nuclear medicine consists of doing a CT scan prior to that PET scan. So they generally have the same technologist doing those studies. There is no dedicated CT school, but there are several CT workshops that are online. They've got online learning modules. There are books you can buy that you can do an at-home self-study course with. So different options. Everyone that works here at Tappahannock, because we're such a rural hospital and we need x-ray and CT coverage 24/7, we cross-train those techs that come in for x-ray to be a CT tech. And in order to do CT, you've got to get that CT registry. So we've got techs that have done all different kinds of, how I like to learn isn't necessarily how my peers like to learn. So we've got techs that have done different types of these CT workshops, whether it be the workbooks at home for the at-home study course, the online courses, or there's even a blended one where you do some stuff at home and then you're doing some stuff online. trying to think if I know of any schools that actually have a CT workshop. I know Bon Secours used to have one. I'm not sure if they still do. And I'm not sure if Riverside does or not. So, but every post-primary certification does have a structured education requirement and a clinical requirement. So it's not just that book work. You're going to actually have to get out into the field of CT and scan patients. So the structured learning requirements for CT, and this is pretty much for any imaging modality, is you have to get 16 hours of education, which in imaging world, we call them 16 CE, so just continuing education credit. And those are ones that are specifically identified by the ARRT that count towards being a CE. And the requirements for CT include patient care, safety, image production, and procedures. So there are, like I said, multiple online programs, home study. Okay, head to the clinical experience. This is where things get a little bit confusing. The structured learning part is pretty straightforward. The clinical experience, though, for each modality that you do is different because you're doing different procedures in each modality. So with CT, you're required to complete a minimum of 125 repetitions of scans. And within those 125, one must complete at least 25 different procedures. So the ARRT, you go on their website, it'll have it listed out. Here are 59 different procedures. You need to pick 25 of these to get you 125 repetitions. In order to count one of those procedures towards your 125 repetitions, you have to do that scan at least 3 times. So once you do them 3 times, you can count all 3 of those, but you can't count them until you complete 3. And you can only count up to 5 of them to get to your 125. That's because they don't want people doing 125 head CTs. And then you don't have any idea how to do a belly scan, or you've never done one. So that's why they require that you doing the different procedures. So you're a very well-versed tech when you come out into the field as a registered technologist. The clinical learning, there are different healthcare schools that you can go through to get set up with an organization to come in to be a student. I know Riverside has it. I think Bon Secours, at least Bon Secours used to. I'm not sure if they still do.
So Amy, I just looked up. So as part of an AHEC initiative with the Virginia Health Workforce Development Authority, we just created a new health career manual, and I'll put the link in the chat. But for CT, the 2 educational programs in Virginia is Riverside College of Health Careers and Centera College of Health Sciences.
Great. Yeah. So I was wondering if Bon Secours still had theirs. We usually get some of their students, and I hadn't seen some. Yeah. That's good. And then, so working with those 2 programs, those 2 health systems, you'd be able to get in to get your clinical training. And then there's always on the job training. So if you're already working at a hospital as an X-ray tech, then, and it's not a place like here where like, yeah, you're going to get CT too. You just go to your manager and ask, you know, I've got this interest. Can I come in and do this on my time off? Most places aren't going to tell you no. So, and it's not always, it doesn't hurt to ask. So once you've completed your clinical requirements and your structured learning, then you've got to go to the ARRT and apply to sit for the registry. So you send them all the evidence of your 125 repetitions you've done and of your structured learning, and then they send you back a letter saying you're good to sit for your test. Here's the day that you can start, and you got to call a testing center and get set up for that. And the good thing now is once you take that test, it'll tell you at the end of it whether you passed or failed. Back when I took it, you had to wait 2 weeks for a letter to come in the mail. Very stressful 2 weeks. So, any questions about CT before I move on from Mammo? Okay, all right. Put anybody to sleep yet? Okay. All right, so mammography. Here are 2 different pictures of mammo units, and this does happen to be the unit that we have at Tappahannock. And it's the same machine in both these pictures, just showing them in different positions that we would use them in. So this is the typical upright position of the mammo machine. That's how it is when anyone walks into Mammo and sees it. That's usually how you're going to find it. And then this little teeny computer over here is the control panel for the Mammo unit. You position your patient at the machine, walk behind the little control panel, and make sure your technique's set correctly and hit the button to take a picture. This is just showing that same machine with it kind of turned to the side that we would use it in to get other views of the breast. When you come in for a mammogram, there are 4 standard pictures that wherever you go, mammo is a screening modality. So anywhere you go, you're going to get these 4 pictures, 2 of each breast, no matter where you go, because that's what is required for the screening test. So the first 2 pictures would be taken with the Mammo unit in this position. And then the second 2 pictures are of it. You turn it to the side for one breast, and then you flip it to the other side for the other breast to get side views of each breast. All right. Let's see what else we got here. So mammography is a screening modality that utilizes ionizing radiation and compression paddles to obtain images of the breast for breast cancer detection. Not only are the screening tests are done in Mammo, that's probably what I'm getting ready to say in my next little point there. So when an area of concern is identified, the patient does return to mammography for additional imaging of the area through different views, which are positions that we put the patient and breast in, and or different imaging techniques such as magnification and compression dedicated to the area of interest. Images can be obtained in 2D or 3D or a 2D, 3D combo. Mammography can also be used to do needle localizations and biopsies. And it is one of the more regulated modalities within the imaging world. So when I say 2D and 3D combo, I'm going to kind of go back to that picture I was just at. And I don't know if y'all notice how the top of this machine is kind of tilted off to the side compared to the rest of it. So Mammo in the last few years, gosh, I'd say maybe last 10, has come up with 3D Mammo. So just like in CT, where you could take pictures and slices of your of the anatomy, you can do the same thing now in Mammo with the breast. Whereas before, that was one of the reasons for all that compression. You want to spread that breast tissue out so you can make sure that there's nothing hiding behind anything in there. With the 3D Mammo, now you don't have to use as much compression because you're taking pictures in thin slices throughout the breast. So it kind of takes away that the issue of things hiding behind things. All right. So the FDA regulates mammography through the Mammography Quality Standards Act, which is the MQSA, that became effective in October of 1994. Mammography facilities are inspected annually by the FDA to ensure the facility is following the regulations. We just had ours passed with flying colors. There are regulations around equipment quality control and QC records, checking the credentials and continuing educations of the technologists performing mammograms and the radiologists that are reading mammograms. So unlike in CT, in order to be a mammo tech, you have to get so many mammos a year. You've got to do 100 mammos a year, and the radiologists have to dictate so many mammos a year. So it's not one of those fields like I can go away from CT for a year, not do a scan, come back into it and start scanning with a little refresher because I'm sure something's changed. Whereas in mammo, if I haven't done 100 mammos in the past year, in order for me to start doing them again, I have to do 25 with a mammography tech who signs off that they were with me for those 25 before I can go back in and do patients on my own. All right, so what is the mammo tech's role? So same thing, you got to get your patient out of that waiting area, and you need to ensure you've got the correct patient, ensure you're doing the correct test, and achieve quality imaging. Those 3 things right there are going to be with whatever imaging modality that you're doing. You also have to review their BI-RAD category reports to call any patients back that need additional views. The BI-RAD categories are what the radiologist puts on the end of their reports to let for tracking and mammo purposes, for if the patient needs to come back for additional views, if they're worried for the patient may have something that needs a biopsy. So they give them these little codes that triggers, and these codes travel wherever the patient goes. It's no different the codes that are used within VCU, Riverside, Centera, Bon Secours, all the same. So if the patient were to go to another facility, they'd see that code and know what that patient needs. So it's up to the mammo tech to review that report and make sure if there's any patients that need to come back in for further imaging, they're called. It's also up to the mammo tech to track the patients that need additional imaging to ensure that they are getting the necessary follow-up. So say we have a patient that comes here, gets her screen and mammogram, then has to come back for those diagnostic additional views. So we hone in on that little area the radiologist saw, and we do that by using, say, a smaller paddle or the magnification, which kind of zooms in on that area. And if that is truly an area and we can't make it go away and doing these different views, then they decide to biopsy it. Once they biopsy it, it depends. And if that patient wants to go somewhere else for a biopsy, we still have to follow that patient to where they go. Call that place. Did the patient get their biopsy yet? Was it positive? Yes. And have to do all of that tracking on that patient to make sure they're getting the care that they need. And that is one of the things that when the MQSA folks come in and do your annual review that they're looking at, is that you're closing the loop with those mammo patients. We also have to perform quality control in mammo. There's daily quality control and weekly quality control to make sure the machine is functioning as it should. And all of that has to be documented. And that is also reviewed during your inspection when they come out each year. All right, so here's some pictures of a mammo. The pictures that are on the left, so you've got a left breast and a right breast, and these are those side views. And then these are the other two pictures that you'd get, again, left breast and right breast. And those are the ones where the patient walks straight up to the mammo unit. And this is just getting the pictures in two different views to make sure that there is nothing, again, hiding anywhere. And if you do see something, that side view kind of tells you where it's at within the breast. So is it up high in the breast or is it kind of down low in the breast? And that's what that picture will help tell you. So over here to the left, these are the different slices that you can get in 3D mammo. And you can, so that the very front of it, that is the nipple, and you can kind of see how that changes throughout the different images as the slices go up through to the top of the breast. And then these are some more images. These are ones that were taken from the 3D mammo with the slices and converted into a 2D mammogram. So once they do that 3D mammogram, they don't always have to go back and do that 2D mammogram that used to be done and is the standard view for screening mammos. All right. So how to become a mammo technologist? Same thing with CT. It's not a primary, so you will have to get your primary radiology background. So again, radiology, nuclear medicine, sonography. No dedicated mammography schools, but several mammo workshops online. Same thing with that. MTMI has a really, really good program. And I know Tidewater Community College used to have one. I did some Googling earlier, but I couldn't find if they still have their online program. I'm gonna skip on that last one. Yep, and same thing. Every post-primary has the structured learning and the clinical requirements. So same thing, you've got to get those 16 hours for 16 CEs for your structured learning within mammography, and those include patient care, image production, and procedures. There are, again, multiple online programs and at-home study courses that can be done for that structured learning. So your clinical experience in mammo is a little bit different than CT. It's not just doing patients. You do have to complete 25 supervised mammography patients, and you have to not just document that for the ARRT, you also have to document that for the FDA for that MQSA inspection. And that's something that's got to stay in your MQSA book every time because they'll look at it every time they come. It's just every year. Complete 75 mammograms. So that'll give you between your 25 supervised and then the 75, that's 100 total mammos you have to do before you sit for your test. You also have to complete quality control tests and documentation. So there are, if you go on the ARRT's website, it kind of breaks out everything you need to do. And it tells you, these are the quality control tests you have to do and document on. You have to sit with an MQSA qualified interpreting physician. So this is going to be any of your radiologists that read mammos. And you have to sit with them for 10 mammo cases, and they have to sign you off on that. And then you also have to assist and observe 4 out of the 11 elective procedures. So those elective procedures they consider are needle localizations, surgical specimen imaging, breast MR, breast ultrasound, stereotactic breast biopsy with clip placement. Needle localization, surgical specimen imaging are 2 things that you could possibly do in mammo departments. The needle localizations are if you find a mass in a breast, identified it as cancer or something that needs to be removed and shouldn't be there, the patient will come to mammo before they go into surgery. So they'll come into mammo, the radiologist will put a wire, basically a guide wire, down into that mass. And then the radiologist will come in, not the radiologist, the surgeon gets the patient and cuts that mass out. And that's how they know exactly where to go and where to find that mass in the breast. The surgical specimen imaging. So once that mass has been removed from the breast, it comes back over to mammo for a picture. And what we're doing with that picture is ensuring the surgeon got the mass. And when they have a biopsy, that clip placement, there's a clip that's placed in the area that's biopsy.